Hello and welcome to the APAC Recap. I'm Viet. I'm a preventive cardiology PA and associate professor of research at Intermountain Health, and I'm a board member for the Academy of PAs in cardiology, the Academy of Physician Associates in Cardiology, or APAC. I'm joined today by the illustrious president, Laura Ross. And I will let her introduce herself in a bit, but we're going to discuss her time at the recent RhAPP meeting. And that's not just rap music, right? You probably sung a few bars, but for those who didn't know or don't know, that's the Rheumatology Advanced Practice Providers meeting. And it's the 5th annual national conference that they held in Nashville this year. But before we go on, let me go ahead and let Laura introduce herself. So Laura, please.
Great. Thanks, Viet. I'm happy to be here to tell you all a little bit more about attending the RhAPP conference. I am current director of the Prevention and Lipid Clinic at the Park Nicollet Heart and Vascular Clinic outside of Minneapolis, Minnesota. And we had so much fun in Nashville learning a little bit more about the intersection between rheumatology and cardiology. Did you know there was so much? You're going to learn today if you didn't. And I was just thrilled to be invited and can't wait to tell you more about that today.
You know, so I always joke about this, but it all comes back to the heart. No matter what else is going on, it seems to be that cardiovascular ends up being one of the primary sequelae that people experience. And so give us a little bit of a rundown of the meeting. Obviously, we just introduced it, RhAPP. How did you get involved with this? And tell me, are people able to do any enduring CME, do late registration, et cetera? Tell me a little bit more about this.
Great question. So RhAPP is run by Focus Med, who is the same CME company who's helping us do our cardiology APP conference next month. And so I was so impressed from the signage to the stash that we got for attending the conference to just making connections and how nice everybody was. It was just overall a really thrilling experience to be there. And the talk I was invited to give was Heart Under Attack, the intersection between autoimmune disease and cardiology. And when I gave my talk, it had a great attendance, especially considering that it was the last talk. I like to call that the keynote speaker, or maybe everyone's leaving to catch their flight, but we captured a good audience. And I think they were surprised to hear that cardiovascular disease is the number one cause of mortality in patients with lupus, with rheumatoid arthritis, with psoriasis. And I attended talks on scleroderma, on, pulmonary hypertension. There's lots of questions about that. And so really helping empower each other. I love what RhAPP did, which is really unique to other conferences I've been to. They did a rheum cardiology talk. They did a rheum ocular talk, a rheum dermatology talk, a rheum pulmonary talk. So there are, main sessions that everybody went to, and then an opportunity to break out to sessions to learn a little bit more, dive deeper in a little more intimate setting with the speakers. So there's great interaction, and really you and I and Viet are pretty biased that the heart is the most important of all of these. And I think I swayed them. Like, yeah, we can get you feeling better, but what's going to help you live longer? And that so often is harder to treat because it's the rheumatological disease that causes symptoms. But what can we do for prevention? Not we got them feeling better. How can we keep them living longer? And so that was fantastic. I think something unique too were some of the hands-on experiences. They did joint injections. They did like a boot camp for new APPs to rheumatology. They did curbside consults. I mean, I wish every conference had sessions like this, really applicable, and lots of chances to intersect with other specialists. And they had me co-present with a rheumatology PA. And so I got to meet this fantastic speaker, Katie Springer, and most of their talks were one or two people working together, whether a nurse practitioner or a PA. I had a great talk about scleroderma with a dermatologist and a PA who kind of helped. She talked about inheriting like 800 patients when her doctor left the practice, and how it was kind of a baptism by fire, learning everything. And she was able to share that with us because there isn't just one provider who can take care of the whole spectrum, of all the things that affect these patients. But it was really inspiring to see how RhAPP is starting to address that gap.
So what are some takeaways for the cardiology PA? I mean, they were surprised And I think you would find that a lot of cardiology PAs would be surprised at how much rheum leads to cardiovascular disease.
Yeah, so in my talk, we talked about pericarditis, and lupus and some of the newer treatments, the drugs that are out there that can really help stop recurrent pericarditis. I think one talk I went to was about Ehlers-Danlos syndrome, which is kind of that gray area of medicine for some people, but to patients, it can be so symptomatic and a cross-section with POTS. And so I learned a lot about how really a specialist in APP and rheumatology has become a magnet for people all over her region because she listens to them. She has tried medications, done a lot of research to really help symptoms. And so, I think some of those things that in cardiology, when we're opening up arteries and putting in TAVRs, these really life-altering diagnoses that have a tie to rheumatology, we should be more aware of, and we should find experts in our community to refer these patients to, because often it is the APPs in cardiology and in rheumatology that are seeing these patients more often than some of our physician colleagues. And so really trying to be in tune to what these manifestations may be and when to reach out to a specialist.
So one of the things that we run into here is rheumatologists and rheumatology PAs are you can't hit one when you throw a rock. You'd have to really search to find one. What can we do to extend that consult so that we can start things? What can we do to help offload rheumatology when we have one in the valley with us? Is there anything that we can do or start or help to offload that while treating their rheum disease and also the risk of cardiovascular disease?
It's a great question. I think sometimes it is drawing in their primary care physician or PA or NP who might have more experience with some of the certain diagnoses, but they did talk about labs that might be, they'd want to see before they do a consultation. I think too, just being aware of some of these newer things that are coming out, like mast cell, activation syndrome, and some acronyms I hadn't even heard about before, that are new on this language. Yes. Oh, goodness. Right. And so just being aware of that and kind of, doing some of the grunt work. What you asked reminded me a little bit about the patients you and I see Viet in our prevention clinic with elevated CK levels. So we did devote part of our talk to what do? You have a patient on a statin, their CK is elevated. Do you send them straight to rheum? And their answer, just like my institution's answer, is no. If they're asymptomatic, population-based studies have shown that depending on muscle mass, you can accept a much higher level of CK that can be considered normal. So a white female has a much different acceptable range for their CK level than, say, a white male. Under 500 could be still normal for a white male who has a larger muscle mass. And so that was interesting to me in that, what labs add LDH, those sorts of things. You want to make sure there isn't an underlying issue, but I'm sure there's opportunities for more things like that where we can help each other out, try to do a little pre-work first.
Yeah, that's great. And that's helpful. So with your talk then, the keynote for the end of the conference, what were some takeaways or do you give us a summary, give us a sense of what you thought our rheumatology colleagues should know or need to know about this, intersection between our two specialties?
Yeah, so I think we talked a lot about evaluating the cardiovascular risk. And I reminded them, when lipids came on the scene, it was really endocrinologists who managed high cholesterol. We didn't have very good medications, but primary care and cardiology were like, that's not our business. It quickly became our business, right? And I had them raise their hand. We had just talked about how the biggest cause of mortality is cardiovascular disease in these patients. How many of you have prescribed a statin? Not one person. And so there's much work to do. And I taught them about the tool in my electronic medical record with Epic. If you type in .CVR for cardiovascular risk it will blow in all their information for the AHA-ACC 10-year risk calculator. And so that's an easy way, if it's over 7.5%, that you could start the conversation, even if you might not be comfortable prescribing the medication, that's something that is available to them, knowing that inflammatory disorders like autoimmune disease is another risk enhancing factor. So even if that percentage might be a little bit lower, if you start to add up other risk factors, age and family history and whatnot, you're going to want to be more proactive. So I think a light bulb went off with some of them too, that could be a part that they play. We also talked about, of course, psoriasis, pericarditis, and lupus, and kind of what are the manifestations, especially with lupus. You can have conduction abnormalities. You can have, different lesions or nodules that start to form on their valves, and that can happen, and what to be aware of. And lastly, talked about a patient case with scleroderma who had pulmonary hypertension. And what I learned from them is they have something called EULAR, which is kind of who makes their recommendations, and they have a whole risk stratification tool for pulmonary hypertension. And as you plug in the patient's information, it will tell you, should you order an echo and how often? Should you consider a right heart cath and how often? So there's really validated tools in the rheumatology space that I didn't know of in cardiology that helps follow these patients. So I think it was really worthwhile on both ends, lots of learning.
Well, it sounds like we need to include a rheumatology section in 2025.
And we are. Katie and I are going to give this talk at CAP in Las Vegas, October 17th to 19th. So we had such a great reception, and I think we all agreed there's a lot to learn here, and it would be a great audience.
So is there, did you learn of any upcoming clinical trials that are coming out that fill both of the spaces for rheum or cardiology and kind of a crossover? Because a lot of this is really, I think, inflammatory based, right? That's kind of the main issue, at least from a cardiovascular perspective. Is this IL-1? Is this IL-6? What's going on, and how do we treat it?
One thing that we learned and talked a little bit about is how some of these drugs and studies have looked at why are autoimmune diseases a risk-enhancing factor, like rheumatoid arthritis, psoriasis, and lupus. And it's thought that it affects the efflux of cholesterol on the HDL particle. So they've measured this and found, even though, for instance, in an acute rheumatoid arthritis flare, LDL goes down and HDL goes up, which old school, we would have been like, that's the right direction.
Right, yeah.
But what we found is those patients are 1.5 times have a higher risk of having a heart attack, if they're an active RA. And so the numbers aren't matching up. And as they've looked at this in research, it's because the cholesterol is doing something different. As we've suspected in other acute illnesses, in the hospital, we know cholesterol is maybe utilized or sucked up a little bit differently to fight something acutely. But this is definitely showing me there's more room for research.
When I think about, that exact presentation, you wonder about when we have observational data showing folks who start to lower their LDL cholesterol, that seems to associate with worse disease. And what I tell folks is that's different than when you intentionally lower LDL cholesterol with therapies. Here, if they have a trend over time of lowering LDL cholesterol just, as serially drawn without intention treatment, often that is a marker of worsening frailty of illness and progression of disease. And so this sounds like that's kind of in that same space, although acutely so, where folks having a flare-up will have a lower LDL and higher HDL. So that's always so interesting to me. We teach things axiomatically, but we forget that the body does different things, right, in different situations. Okay, so coming back to RhAPP then, because I want to make sure that they have folks coming to a conference that's appropriate and really, it sounds like more than just rheumatology might be interested in going to RhAPP next year. Who would you think? Who should go?
Oh, who shouldn't go is the better question, right? So we've got, they're touching on dermatology, they're touching on, interstitial lung disease and pulmonology, where, I think primary care APPs would be great, internal medicine, urgent care, like how do you kind of assess the onset of symptoms, which often is where these present, cardiology, research like you, Viet. I think there's lots of people who would benefit and learn a lot. And I think just meeting even Katie Springer and some of the other speakers, there is such a wealth of knowledge out there, and I think this APP network that GAP and RhAPP and CAP is helping foster and facilitating some of this crossover and learning from each other is just fantastic. And I don't think there's anyone who wouldn't learn something from a conference like RhAPP.
Well, I certainly, you've whet my appetite to at least hear from your presentation, but also to learn more. I think it's something that, obviously, if more folks understood some of these basic tenets of the disease itself, the sequelae of rheumatologic disorders, and then what we can do to help prep a patient for consult, those labs that are appropriate versus not, what's really the rheumatology consult person looking at it and needing, so that we don't put them back on the assembly line, back on the schedule after they should have ordered this and now I have to wait another 3-6 months. So that's always helpful. As we are there any final thoughts that you have before we kind of come to a conclusion here?
I don't think so. I think this is just a great conference, well run, great connections, lots of time to interact. Not that you had to make 1,000 of your own decisions about what talks to attend, which some of these larger conferences can happen, but still built-in time to really personalize your experience at the conference was great. And with our talk, as well as the others I attended, they did a great job of starting with case studies. So it made it really personable, compared to rattling off some statistics of a study. Here's my patient with pericarditis, 24 ER or clinic visits in 2 years. I worked with a rheumatologist at a different institution. So, that's like landing on the moon. And be able to coordinate one of these new medications to help with pericarditis, even though it's rare to have an outcomes trial in these patients. They're often excluded from trials like for treatment for pericarditis, but in some of the reviews, great outcomes. So her rheumatologist and I thought it was worth it. And I looked back on her chart recently, and for 2 whole years, she hasn't had another visit for pericarditis. And so it's stories like that help that information stick. And really, we want to share that because some of these cases are unique. And I think this is an opportunity to do that.
Yeah, I love that. I think, honestly, and now you're making me think whether or not I added cases. I tried to, but it's always nice to give a framework, because that's how we think, right, as clinicians, is how do I, what will I do on Monday when I return to clinic? And it's always nice to start with a case to give the framework, to help with the storytelling, because the data will fit. The data will fit if you give a vignette. So as we kind of come to a close here, I just want to remind folks, we have the CAP Live conference in Las Vegas, October 17th through the 19th. I'm so very excited. Our president here, Laura Ross, is faculty, as am I. And there are just a lot of invited speakers that they really have a wealth of knowledge. There's a great bevy of topics, actually, all of which I think you'll, if you attend with us, please do. You'll be happy that you took the time to come join us as PAs in cardiology at CAP Live in Las Vegas. So again, the registration should be included, I think, in the link as we post this video, and just click on it and register. I think you'll also want to become a member of the Academy of PAs in Cardiology. We have other activities for members and extra benefits as well. So here we are, as a cardiology provider. I hope to see you all there. If you want to learn more, you can come to our website at APAC, that's cardiologypa.org, and then you can go to the CAP Live conference at CAP, that's 2 P's, right? CAPPlive.com. And thank you again, Laura. Appreciate all of your wonderful experiences that you've been able to share with us.
Thanks, Viet. We hope to see you in Las Vegas.
Okay, thanks for tuning into this episode of the APAC Recap. And you can find this episode and more at the HCP Live as well as on YouTube. See you next time.